Morphine. Expanded lecture note. Welcome to our lecture on morphine, a powerful opioid analgesic that has been a cornerstone in pain management for centuries. Morphine is widely used to relieve moderate to severe pain, particularly in acute and chronic settings. In this lecture, we will explore its mechanism of action, clinical uses, potential side effects, and important considerations for its use. Let's dive into the world of morphine and understand its role in modern medicine. Objectives. By the end of this presentation, learners should be able to 1. Define morphine and understand its origin. 2. Describe its history, myths, and clinical significance. 3. Discuss its classification, properties, and mechanism action. 4. Explain its pharmacokinetics and pharmacodynamics. 5. Outline storage, disposal, and drug interactions. 6. Identify clinical uses, including ICU, anesthesia, and emergency settings. 7. Recognize side effects, contraindications, and precautions. 8. Compare morphine with other opioids. 9. Appreciate current trends, ongoing research, and patient education. 10. Conclude with professional insights and take-home messages. Other names. 1. Trade names: Roxanol, MS Contin, Cadian, Avinza, Morphitec. 2. Street names: Abuse Context M, Miss Emma, White Lady, God's Drug. Introduction to morphine. 1. Morphine is the standard opioid analgesic used for comparison with other opioids. 2. It is a crucial medication for treating moderate to severe pain. 3. Morphine is used in various medical settings, including perioperative care, critical care, palliative medicine, and emergency medicine. 4. It is derived from the opium poppy, a natural source of opioids. 5. Morphine has been in clinical use for over 200 years, demonstrating its long-standing effectiveness and importance in pain management. Introduction. 1. Natural origin. Morphine is derived from the opium poppy, Papaver somniferum, a plant that has been used for centuries for its medicinal properties. 2. Historical significance. Morphine was first isolated in 1804 by Friedrich Serturner, who named it after Morpheus, the Greek god of dreams, due to its sedative effects, highlighting its long history of use in medicine. 3. Gold standard for pain management. Morphine remains the gold standard for severe pain management, particularly in cancer pain, as recommended by the World Health Organization's WHO ladder for cancer pain, underscoring its effectiveness in managing severe pain. 4. 1. Research findings. Studies have consistently shown that morphine is effective in managing various types of pain, including acute, chronic, and cancer pain, making it a versatile and valuable medication. 2. Addiction potential. Morphine has a significant potential for addiction, which has led to strict regulation and careful prescribing practices to minimize the risk of dependence and abuse. 3. Role in anesthesia and palliative care. Morphine plays a vital role in anesthesia and palliative care, where its potent analgesic effects are used to provide relief from severe pain and improve the quality of life for patients with terminal illnesses. The myths about morphine. Myth 1. Morphine always causes addiction. Fact. When used appropriately under medical supervision, dependence risk is low. Myth 2. Morphine is only for dying patients. Fact. It is widely used for perioperative, trauma, and ICU pain. Myth 3. Morphine causes respiratory arrest in all patients. Fact. Respiratory depression is dose-related and manageable with monitoring. Myth 4. Morphine shortens life in palliative care. Fact. Proper dosing improves quality of life and does not hasten death. Definition of morphine. Morphine is a naturally occurring opioid alkaloid that acts primarily as a mu-opioid receptor agonist, producing analgesia, sedation, and respiratory depression. 1. Morphine is a naturally occurring opioid alkaloid, meaning it is derived from a natural opium poppy. 2. It acts primarily as a mu-opioid receptor agonist, which means it binds to specific receptors in the brain and body. 3. Morphine's action produces several effects, including analgesia, pain relief, sedation, calming or inducing sleep, respiratory depression, slowing down breathing rate, which can be a potential side effect. History of morphine. 1. 1804. Morphine was isolated by Friedrich Serturner, a German pharmacist, marking a significant milestone in the understanding of the substance. 2. 1827. Morphine was first marketed by Merck, making it more widely available for medical use. 3. 1853. Morphine began being used with hypodermic syringes for pain relief, allowing for more direct and effective administration. 4. 20th century. Morphine saw widespread use in war medicine, particularly for treating wounded soldiers, highlighting its importance in emergency care. 5. Today, morphine is controlled under international narcotics regulation due to its potential for abuse and addiction, reflecting the need for careful management and oversight. Classification of morphine. 1. Pharmacological class. Morphine is classified as an opioid analgesic, meaning it works by interacting with opioid receptors in the body to relieve pain. 2. Therapeutic class. Morphine is categorized as a narcotic analgesic, indicating its use for treating severe pain. 3. Controlled status. Morphine is classified as a Schedule II controlled substance, signifying that it has a high potential for abuse and dependence, and its use is strictly regulated. Chemical properties of morphine. 1. Chemical name. The complex chemical name 5-alpha, 6-alpha-7, 8-dihydrohydro4, 5-epoxy-17-methylmorphinan3, 6-diol describes morphine's molecular structure. 2. Molecular formula. C17H19NO3 represents the composition of morphine, indicating the number of carbon, hydrogen, nitrogen, and oxygen atoms. 3. Molecular weight. 285.34 gram per mole is the molecular weight of morphine, which is a measure of its molecular mass. 4. Structure. Morphine is a phenanthrene alkaloid, meaning it has a specific 3-ring structure characteristic of this class of compounds. 5. pKa. Morphine has a pKa of approximately 8.0, indicating it is a weak base, which influences its behavior in different pH environments. Physical properties of morphine. 1. Appearance. Morphine typically appears as a white crystalline powder. 2. Solubility. Morphine is freely soluble in water, especially when formulated as morphine sulfate or morphine hydrochloride, making it suitable for various administration routes. 3. Formulations. Morphine is available in several forms, including injectable solution for direct administration, oral tablets immediate and extended release for pain management, oral solution for patients who have difficulty swallowing tablets, rectal suppositories for alternative administration, epidural intrathecal preparations for regional pain relief. 4. Stability. Morphine is stable at room temperature, but it should be protected from light to maintain its potency and effectiveness. Mechanism of action of morphine. 1. Primary action. Morphine acts as a mu-opioid receptor agonist, binding to specific receptors in the brain, spinal cord, and peripheral tissues. 2. Inhibits ascending pain transmission pathways. Morphine blocks transmission of pain signals to the brain, reducing the perception of pain. 3. Increases potassium efflux, hyperpolarization. Morphine increases the flow of potassium ions out of neurons, making them less likely to fire and transmit pain signals. 4. Decreases calcium flux. Morphine reduces the flow of calcium ions into neurons, which decreases the release of neurotransmitters involved in pain transmission. 5. Inhibits neurotransmitter release. Morphine reduces the release of pain-related neurotransmitters, such as substance P and glutamate, for contributing to pain relief. 6. Produces analgesia, sedation, and euphoria. Morphine's action on mu-opioid receptors leads to pain relief, relaxation, and feelings of well-being. 7. Depresses respiratory centers in the medulla. Morphine slows down breathing rates by affecting the brain's respiratory centers, which can be a potential side effect. Pharmacokinetics of morphine. 1. Absorption. Morphine is well absorbed orally, but its bioavailability is low, approximately 20 to 40%, due to extensive first-pass metabolism in the liver. 2. Distribution. Morphine is widely distributed throughout the body, but its slower CNS penetration compared to fentanyl affects its onset of action. 3. Protein binding. Morphine is approximately 30 to 35% bound to plasma proteins, which influences its distribution and elimination. 4. Metabolism. Morphine undergoes hepatic glucuronidation, resulting in two main metabolites. Morphine 3-glucuronide, inactive. Morphine 6-glucuronide, active and potent analgesic. 5. Elimination. Morphine is primarily eliminated through the kidneys, with its metabolites secreted in the urine. 6. Half-life. The half-life of morphine is 2 to 4 hours, but it may be prolonged in patients with renal impairment, affecting dosing and accumulation. Pharmacodynamics of morphine. 1. Onset IV. Morphine takes effect within 5 to 10 minutes when administered intravenously, providing rapid pain relief. 2. Onset oral. When taken orally, morphine's onset of action is 30 to 60 minutes, which is slower than IV administration. 3. Peak effect. The peak effect of morphine is reached in approximately 20 minutes after IV administration and 60 minutes after oral administration. 4. Duration. The duration of morphine's effects varies depending on the formulation. Immediate release. 3 to 4 hours. Extended release. Up to 12 to 24 hours, providing longer-lasting pain relief. 5. Effects. Morphine produces several effects, including analgesia, pain relief, sedation, calm-inducing sleep, respiratory depression, slowing down breathing rate, miosis, constriction of the pupils, cough suppression, reducing cough reflex, euphoria, feeling of intense happiness or well-being. Storage and disposal of morphine. 1. Storage. Morphine should be stored in tightly sealed containers to prevent moisture and air exposure. 2. Light protection. Containers should be light resistant to prevent degradation of the medication. 3. Room temperature. Morphine should be stored at room temperature, away from extreme temperatures. 4. Controlled drug storage. As a controlled substance, morphine requires strict accountability and storage in locked containers to prevent diversion or misuse. 5. Disposal. Morphine should be disposed of through incineration or according to hospital narcotics policy, ensuring safe and secure destruction of the medication. Drug interactions with morphine. 1. CNS depressants. Benzodiazepines. Alcohol. Combining morphine with these substances can increase the risk of respiratory depression, a potentially life-threatening condition. 2. MAOIs. Monoamine oxidase inhibitors. More can interact with MAOIs to cause serotonin syndrome, a serious condition characterized by excessive serotonin levels, and hypertensive crisis, a sudden and severe increase in blood pressure. 3. Antihypertensives. Morphine can enhance the blood pressure-lowering effects of antihypertensive medications, potentially leading to additive hypotension, low blood pressure. 4. Other opioids. Combining morphine with other opioids can result in synergistic effects, increasing the risk of overdose, respiratory depression, and other adverse effects. Clinical uses of morphine. 1. Acute pain management. Morphine is used to treat severe pain resulting from surgery, trauma, or burns, helping patients manage their discomfort during recovery. 2. Chronic pain. Morphine is effective in managing chronic pain, particularly in cancer patients, improving their quality of life. 3. Analgesia in myocardial infarction. Morphine provides pain relief during heart attacks, reducing the physical and emotional distress associated with this condition. 4. Relief of dyspnea. Morphine alleviates shortness of breath in patients with acute pulmonary edema or end-stage heart failure, improving their comfort and reducing anxiety. 5. Palliative care and hospice. Morphine is used to provide pain relief and improve the quality of life for patients with terminal illnesses, focusing on comfort symptom management. 6. Epidural or spinal administration. Morphine can be administered epidurally or spinally for postoperative or obstetric analgesia, providing effective pain relief with potentially fewer side effects. Use of morphine in ICU. 1. Continuous infusion. Morphine is administered as a continuous infusion to provide consistent analgesia for mechanically ventilated patients, ensuring their comfort and reducing stress. 2. Pain control. Morphine is used to manage pain in critically ill patients with trauma, burns, or post-surgical conditions, helping to alleviate their discomfort and promote recovery. 3. Relief of dyspnea. Morphine is effective in relieving shortness of breath in patients with severe pulmonary edema, improving their respiratory comfort and reducing anxiety. 4. Caution in renal impairment. Morphine is often avoided or used with caution in patients with severe renal impairment due to the risk of accumulation of its active metabolite, morphine 6-glucuronide, which can lead to increased sedation and respiratory depression. Use of morphine in anesthesia. 1. Preoperative or intraoperative analgesia. Morphine is administered to provide pain relief before or during surgery, often given after induction to minimize discomfort and stress. 2. Postoperative pain control. Morphine is used to manage pain after surgery, and patient-controlled analgesia (PCA) allows patients to self-administer doses as needed, providing effective pain relief. 3. Neuraxial anesthesia. Morphine is combined with local anesthetics in neuraxial anesthesia, such as epidural or spinal anesthesia, to provide extended pain relief, reducing the need for additional pain medications. Use of morphine in emergencies. 1. Acute myocardial infarction. Morphine is used to provide analgesia for heart attack patients, reducing pain and preload, the initial stretching of the cardiac myocytes prior to contraction, which can help decrease the workload on the heart. 2. Severe trauma or burns. Morphine is administered to control severe pain resulting from trauma or burns, helping to alleviate discomfort and promote patient stability. 3. Acute pulmonary edema. Morphine helps relieve symptoms of acute pulmonary edema by causing vasodilation, widening of blood vessels, and anxiolysis, reduction of anxiety, which can improve patient comfort and reduce respiratory distress. Nursing management of morphine. 1. Pain assessment. Nurses assess pain levels before and after morphine administration to determine the effectiveness of the medication and adjust dosing as needed. 2. Monitoring vital signs. Nurses monitor respiratory rate (RR), oxygen saturation (SpO2), blood pressure (BP), and heart rate (HR) to detect any adverse effects of morphine. 3. Sedation monitoring. Nurses watch for signs of excessive sedation, which can be a sign of morphine toxicity or overdose. 4. Constipation management. Nurses anticipate and manage constipation, a common side effect of morphine, by encouraging fluids, fiber, and potentially administering laxatives. 5. Patient education. Nurses educate patients about the safe use of morphine, including potential side effects, dosing instructions, and the importance of reporting concerns. 6. Narcotic accountability. Nurses ensure accurate narcotic count and documentation to prevent diversion and maintain patient safety. Administration and dosage of morphine. 1. IV bolus. For acute pain, 2 to 4 mg of morphine is administered intravenously every 5 to 15 minutes as needed, with dosing titrated to achieve the desired effect. 2. IMSC. Intramuscular or subcutaneous administration typically involves 5 to 10 mg of morphine every 4 hours as needed. 3. Oral. Immediate release oral morphine is usually given in doses of 10 to 30 mg every 4 hours. 4. PCA patient-controlled analgesia. PCA settings typically include a loading dose of 1 to 5 mg, a demand dose of 0.52 mg, and a lockout interval of 6 to 10 minutes, allowing patients to self-administer medication as needed. 5. Epidural. For epidural administration, a bolus dose of 2 to 5 mg is often given, followed by a continuous infusion of 0.1–0.5 mg per hour, providing effective pain relief. Side effects of morphine. 1. Sedation, drowsiness. Morphine can cause feelings of sedation and drowsiness, which can impact a patient's ability to perform daily activities. 2. Nausea, vomiting. Morphine can stimulate the chemoreceptor trigger zone in the brain, leading to nausea and vomiting in some patients. 3. Constipation. Morphine reduces gastrointestinal motility, leading to constipation, which can be a persistent and uncomfortable side effect. 4. Miosis. Morphine causes pinpoint pupils miosis due to its effect on the autonomic nervous system, which can be a characteristic sign of opioid use. 5. Pruritus. Morphine can cause itching pruritus due to histamine release, which can be uncomfortable and may require treatment. 6. Orthostatic hypotension. Morphine can lead to a drop in blood pressure when standing up, resulting in dizziness or lightheadedness, particularly when changing positions quickly. Serious side effects of morphine. 1. Respiratory depression and apnea. Morphine can slow down breathing rates, potentially leading to respiratory depression and apnea, pauses in breathing, which can be life-threatening if not monitored and managed properly. 2. Severe hypotension or shock. Rapid IV administration of morphine can cause a significant drop in blood pressure, potentially leading to severe hypotension or shock. 3. Anaphylactoid reactions. Morphine can trigger histamine release, leading to anaphylactoid reactions, which can manifest as rash, itching, or even anaphylaxis in severe cases. 4. Tolerance, dependence, and withdrawal syndrome. Long-term use of morphine can lead to tolerance, needing higher doses for the same effect, physical dependence, and withdrawal symptoms when the medication is stopped or reduced. 5. Neurotoxicity. In patients with renal failure, morphine metabolites can accumulate and cause neurotoxicity, leading to symptoms such as confusion, agitation, and seizures. Contraindications for morphine. 1. Known hypersensitivity. Morphine is contraindicated in patients with a known hypersensitivity to morphine or other opioids, as it can trigger allergic reactions. 2. Severe respiratory depression. Morphine is contraindicated in patients with severe respiratory depression who are not receiving ventilatory support, as it can further compromise breathing. 3. Acute or severe bronchial asthma. Morphine is contraindicated in patients with acute or severe bronchial asthma in unmonitored settings, as it can worsen respiratory function. 4. Paralytic ileus. Morphine is contraindicated in patients with paralytic ileus, a condition where the intestines stop moving, as morphine can further slow down bowel motility and worsen the condition. Precautions for morphine use. 1. Renal impairment. Use caution in patients with renal impairment, as morphine 6-glucuronide, an active metabolite, can accumulate and increase the risk of adverse effects. 2. Elderly and debilitated patients. Reduce the dose of morphine in elderly and debilitated patients, as they may be more sensitive to its effects and more susceptible to side effects. 3. Concomitant CNS depressants. Use caution when administering morphine with other CNS depressants, as the risk of additive effects, such as respiratory depression sedation, is increased. 4. Head injury or increased intracranial pressure. Morphine may mask neurologic signs in patients with head injuries or increased intracranial pressure, making it challenging to monitor their condition. 5. Hypotension or hypovolemia. Morphine worsen hypotension or hypovolemia, so use caution in patients with these conditions to avoid exacerbating their hemodynamic instability. Advantages of morphine. 1. Gold standard for severe pain relief. Morphine is considered a gold standard for treating severe pain due to its effectiveness and rapid onset of action. 2. Multiple routes of administration. Morphine can be administered through various routes, including oral, intravenous, intramuscular, subcutaneous, and epidural, providing flexibility in treatment options. 3. Active metabolite. Morphine 6-glucuronide, an active metabolite of morphine, prolongs analgesia by contributing to the medication's pain-relieving effects. 4. Effective for dyspnea. Morphine is effective in relieving dyspnea, shortness of breath, in patients with cardiac or respiratory failure, improving their comfort and quality of life. Disadvantages of morphine. 1. Histamine release. Morphine can cause histamine release, leading to hypotension, low blood pressure, and itching, which can be uncomfortable for patients. 2. Slower onset and less lipid solubility. Compared to fentanyl, morphine has a slower onset of action and is less lipid soluble, which can affect its rapid pain-relieving effects. 3. Accumulation in renal impairment. Morphine can accumulate in patients with renal impairment, increasing the risk of toxicity and adverse effects. 4. High risk of constipation. Chronic use of morphine can lead to a high risk of constipation, which can be a persistent and uncomfortable side effect for patients. Clinical considerations for morphine use. 1. Titration and monitoring. Always titrate morphine to effect while closely monitoring respiratory status to avoid respiratory depression and ensure safe administration. 2. Renal impairment. In patients with renal impairment, consider alternative opioids like fentanyl or hydromorphone to avoid accumulation and potential toxicity. 3. Constipation management. Treat constipation prophylactically in patients on chronic morphine therapy to prevent discomfort and potential complications. 4. Naloxone use. In cases of severe respiratory depression, administer naloxone 0.04-0.4 mg IV, and repeat as needed to reverse opioid-induced respiratory depression. 5. Hemodynamic monitoring. Monitor hemodynamics closely in hypovolemic patients receiving morphine, as it can exacerbate hypotension and compromise patient stability. Comparison of morphine with other agents. 1. Morphine. Onset of action IV, 5 to 10 minutes. Duration of action, 3 to 4 hours. Potency. Baseline comparison, histamine release, yes. Renal safety. Use with caution to potential accumulation. 2. Fentanyl. Onset of action IV, 1 to 2 minutes. Duration of action, 30 to 60 minutes. Potency. Approximately 100 times more potent than morphine. Histamine release. Minimal. Renal safety, safe. 3. Hydromorphone. Onset of action IV, 5 minutes. Duration of action, 2 to 4 hours. Potency. Approximately 7 times more potent than morphine. Histamine release. Minimal. Renal safety, safe. 4. Fentanyl. Onset of action IV, 1 minute. Duration of action, 5 to 10 minutes. Potency. Approximately 100 times more potent than morphine. Histamine release. Minimal. Renal safety, safe. Additional information about morphine. 1. Benchmark opioid. Morphine remains the benchmark opioid for the World Health Organization's WHO analgesic ladder, a framework for managing pain in patients. 2. Chronic cancer pain. Extended-release oral formulations of morphine are commonly used to manage chronic cancer pain, providing sustained pain relief over a longer period. 3. Neuraxial morphine. Administering morphine neuraxially into the epidural or spinal space can provide long-lasting pain relief, but it also increases the risk of delayed respiratory depression, a potentially life-threatening side effect. Current trends in morphine use. 1. Palliative care. Morphine remains widely used in palliative care for managing severe pain in patients with terminal illnesses, improving their quality of life. 2. Postoperative pain. Morphine is still commonly used for postoperative pain management, providing effective relief for patients recovering from surgery. 3. ICU shift to fentanyl. In intensive care units (ICUs), fentanyl is increasingly replacing morphine in many protocols due to its hemodynamic stability and lack of active metabolites, which can accumulate and cause adverse effects. 4. Multimodal analgesia. There's a growing emphasis on multimodal analgesia, an approach that combines different pain management strategies to reduce opioid use and minimize side effects, promoting safer and more effective pain relief. Patient education on morphine. 1. Purpose of morphine. Explain to patients that morphine is prescribed to manage severe pain, and that it works by blocking pain signals to the brain. 2. Adherence to prescribed dose. Emphasize the importance of taking morphine exactly as prescribed by the healthcare provider, and not exceeding the recommended dose to minimize the risk of side effects. 3. Driving and alcohol use. Warn patients about the potential risks of driving or operating heavy machinery while taking morphine, and advise against consuming alcohol, which can increase the risk of adverse effects. 4. Reporting side effects. Encourage patients to report any side effects, such as constipation, nausea, or dizziness, to their healthcare provider, so that they can be managed promptly. 5. Constipation management. Specifically encourage patients to report constipation, and discuss strategies for managing it, such as increasing fluid intake, fiber, and physical activity. 6. Addressing myths and fears. Reassure patients about common myths and fears surrounding morphine use, such as addiction or loss of control, and provide accurate information to alleviate their concerns. Conclusion on morphine. 1. Gold standard opioid. Morphine remains the gold standard opioid for managing severe pain, due to its effectiveness and well-established use. 2. Value in various pain settings. Despite the availability of newer opioids, morphine continues to be invaluable in various pain settings, including acute, chronic, and palliative pain management. 3. Selective use in ICU. In intensive care units (ICUs), morphine use is more selective, taking into account its potential effects on renal clearance and histamine relief, which can impact patient stability. 4. Enduring relevance. Morphine's enduring relevance in pain management is a testament to its efficacy and the essential role it plays in providing relief to patients with severe pain. Take-home tips for morphine use. 1. Titrate to individual need. Always titrate morphine to the individual patient's need, adjusting the dose to achieve effective pain relief while minimizing side effects. 2. Monitor for respiratory depression. Closely monitor patients for signs of respiratory depression, a potentially life-threatening side effect of morphine. 3. Vigilance in high-risk patients. Be particularly vigilant when administering morphine to patients with renal failure and elderly patients, who may be more susceptible to adverse effects. 4. Naloxone availability. Ensure that naloxone is readily available in emergencies, as it can rapidly reverse opioid-induced respiratory depression. 5. Patient and family education. Educate patients and their families about morphine use, benefits, and risks, to remove fear and myths, promote safe and effective use of the medication. Professional quote on morphine. Morphine is the cornerstone of pain management, enduring, effective, and unmatched in its history of relieving human suffering. Pain medicine principle. This quote highlights morphine's long-standing role and effectiveness in managing pain, emphasizing its significance in the field of pain medicine and its ability to provide relief to those suffering from severe pain. Thank you for watching. If you liked this content, don't forget to like to show your support, comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.